in the CAMHS.
Sorry, Laura.
That's all right. And just to point out, James, who's on the call, is a trainee clinical psychologist in CAMHS, so he's joining me basically. So I'm going to share my screen. I'm not as organised as I should be, so that you can all see some slides. So can everybody see that?
Yes, yeah,
brilliant.
That's working.
So today we're talking about autism spectrum disorder in girls, and I guess I'm really focusing on what's the difference between girls and boys, how do we pick these up, what do we know that's different, and how does it present differently. There is a little bit of information about what that means and what we do with that, but I think I was just saying to Jill before we started, we might have to have a second one on sort of treatment management of girls with ASD, but we'll make some time for questions at the end. Jill, how long have I got? Sorry. Oh, you're on mute.
Of course I am. An hour, or a bit longer if you need it. You know, we're fairly flexible.
Fine. And we can have time. So I won't be speaking for an hour, so we'll have time for questions and things. Great.
Great, thank you.
Okay, so where do we start? I'm just going to start with the slideshow. Sorry. There we go. So, as I said, I'm Laura, and we're going to talk about autism in girls. So today we're going to think about the difference between autism in girls and boys, what we know about girls and how it presents, something called camouflaging, or you may have heard of masking, that's another term people use a lot, how to support a girl with autism, and the strengths of autism in girls. So I'm just going to start here. You probably know some of these people, you might not know others, but there's quite a few famous women out there with autism. So Greta Thunberg is one that's quite famous, that has been quite around the last couple of years, who is a 16-year-old Swedish schoolgirl and climate change activist. She's been nominated for a Nobel Peace Prize, and she's addressed her views on climate change around the UK Parliament, across the world now. And I guess what comes out in her autism is her extreme interest and determination, and I suppose her ability not to be scared of what she says to others. So those are her kind of autistic traits that are actually working really well in her favour. We've got Jack Munro, who is a food writer, journalist, activist. They're a writer in the Guardian newspaper. They do lots of cooking stuff, and got really kind of creative cooking because they use their imaginative use of ingredients to manage, to kind of is a strength that's come out of their autism. I won't go through them all, but we've got Paralympic swimmers who also have autism. Temple Grandin, who is, you may have seen, she's got lots of stuff on YouTube. She's very famous in the USA, and talks a lot about her experience of ASD. And then we've got quite a lot of actresses, which is interesting, and we'll talk about that as we go through. But the idea that you can sort of mask your symptoms and also kind of take on different roles and copy other people seems to be that acting is quite a good career path for women with autism. So our awareness of ASD in girls is really changing. So these are articles actually that I used in a presentation about 10 years ago. So they're actually really out of date. But at the time they were saying things like, it's not just a boy thing, so we're letting down girls with autism. We were starting to recognize that autism was different in girls, and we were starting to sort of notice that the interests were different. So we always think about boys having autism as being interested in trains and timetables, but actually girls can do things like become very interested in things that are very socially appropriate, like the ballet, but then they take on those kind of autistic determination and special kind of ability to memorize things or to learn everything about something. So there was a girl that was 10 who had with autism who had memorized the entire routine for a ballet, which was very impressive. So we know that the characteristics of autism, when we're looking at diagnostic criteria, we're looking at the kind of differences in communication skills and imagination, difficulties predominantly with sort of social interaction skills, how they relate to other people, how they manage friendships. And we're also looking at this other part of the criteria, which is around repetitive interests, stereotype behaviours, inflexibility, differences of change, differences around how they process sensory input. So this has to be met by girls and boys when we're doing the diagnostic criteria. But there are some differences, and I suppose what I should say is, since those articles were written in 10 years, I think we've come an awful long way. And I think that articles, if we were to look for them now, would be quite different. So we know that if we were to look at the differences in boys and girls, we might look at kind of areas of play. So boys can be really repetitive and limited in their areas of play. So you might find a boy would, I don't know, get a train, just move it up and down, no imaginative play, it just goes around the track. Whereas a girl may be less repetitive in what they do and have a broader area of play. So one of the tests that we always talk about is when we're looking at younger children, is we get a dolly out and you kind of get the dolly to go to bed, and you put the dolly to bed and the dolly goes to a birthday party, and it's like a really sociable play event. And actually boys don't have a clue what to do with it when they've got autism, whereas girls can follow that routine, but they're quite repetitive with it, and they can they perhaps get really stuck on some of the details in it. So like, what does the cake look like and how particular do I put the candles in? But they are able to follow the routine of a girl getting a baby to sort of blow out the candles and go to bed. So you see more typical play than you do in boys with autism. So then we also have differences in kind of social communication. So it's usually quite obvious in boys where we've got a diagnosis, but within girls it can be much more subtle. So you might have girls that follow other, they're part of a group at school, but maybe on the edge. They manage the demands in early childhood. They may be that other girls take them under their wing and sort of support them through those kind of social interactions until we get to about adolescence. We may have differences in behaviour, so boys are much more disruptive, girls tend to be less disruptive, and that can change the way they present in a classroom and change the way the sort of problems are highlighted. Like, they may not be highlighted in girls because they fit in, they sit quietly, they do their work. I've already said a bit about changes in interest. So boys more likely to be into transportation, schedules, timetables. Girls maybe more have intense interests about pop stars or fashion. So it seems like a very typical interest for a girl, but the quality is maybe different. And then some of the things that we have with girls, they may be more passive and withdrawn, so less noticeable. They may still be able to do some of the non-verbal communication, like pointing and following gaze and using eye contact, and they are more likely to have those sort of internalizing difficulties such as anxiety and depression, which can mask an underlying social communication disorder. So research into girls with ASD. We know that ASD is more common in males than females, and I've got some statistics later, but it's still the case, but the gap is closing. There's uncertainty about why there's this sex discrimination, that girls are often diagnosed later, and I think that still maintains the case, and I'll talk a bit more about that. There's a higher prevalence of learning disabilities in girls. So I think this is about what we pick up. So if you've got a learning disability, you're more likely to then get diagnosed with autism than if you don't have a learning disability. So I imagine that actually it may not be the learning disability may be the red herring. It may be just that because you have a learning disability, we can pick up the autism easier. I've already said about diagnostic overshadowing. So this is where a young person may have OCD or anorexia or severe anxiety, and that's what they present to services with, and that's what's treated. And it's only through the difficulties of doing that treatment that we recognize that maybe there is an autism spectrum disorder as well. And there's lots of evidence about there being a male brain compared to a female brain. And so this makes some of the traits more obvious in males that maybe don't appear so much in females. And we know they present very differently. So this is just a table about, so this is based on a piece of research by somebody called Will Mandy that I used to work with. And he looked at around 300 samples. I used to work at the social communication clinic in Great Ormond Street, and effectively they collected data on everybody that came through the clinic. So they looked at the differences in what was reported in the 3DI, which is like the diagnostic interview, and they noticed that there were no differences in the social communication impairment. So what is reported tends to be the same. So you still get children that are not invited to parties, that are very literal in their language, that are misreading emotions. So those kind of subtle differences are there, but actually the core questions and the core answers are the same. But when you're thinking about the repetitive and stereotype behaviors, there was real difference. So boys had much more noticeable and obvious repetitive stereotype behaviors than girls when assessing. And this, again, can be because they cover it up, or because they're doing things that are repetitive that they're not showing to the outside world. So, for example, having rituals in their head, or ways they do things in their routine and bedroom that other people are not seeing, they're not witnessing, how they have to turn the sheets on the bed, or how they have to line up the books in their bedroom. Whereas boys, it's much more obvious. They found no differences in IQ. So if you take away if you look at learning disability, there's no difference. And if you look at sort of higher functioning children, no difference between them in terms of what they're presenting with. We saw girls have more internalizing difficulties, boys have more externalizing difficulties, which follows a normal pattern of development as well. And for some reason, there was differences in fine motor skills. So boys tend to be more, I suppose, clumsy, difficult doing buttons, difficulty with handwriting, whereas this didn't seem to be an indicator in girls with ASD. So here's my statistics. So the male-female ratio was 5 years ago 4.4 to 1. So that means every 4 boys there'd be 1 girl diagnosed. Now it's every 3 boys, 1 girl diagnosed. So it's going down, which means that we're picking it up more. I think it doesn't mean it's increasing in girls. I think it's just that we're more aware of it. So the DSM-5 is a statistical book that basically looks at what makes a diagnosis, I think is the best way to describe it. So they have done based on loads of research, have made the diagnostic criteria for autism. And in the DSM-4, which was the one before, it didn't really have this differential between girls and boys. And it's based on the research over the last sort of 15, 20 years that they've then based the next DSM-5, which really thinks about girls, which is quite good. It's impressive how they do it. But there's still things that maybe are not as clear as we'd like them to be. So there's a subtle, we know there's a subtle manifestation. So social communication difficulties are more subtle in girls on the spectrum. And they've picked that up, and then they've used that to sort of develop their criteria. So they say that we know that autistic girls tend to be diagnosed later than boys. And this is often because of co-occurring difficulties that come to the clinical attention. So if they've got OCD, they'll get referred to, say, CAMHS, then they'll start getting treatment, and then somebody might say, oh, I'm wondering about this. Maybe they've got autism. And symptoms may be present in an earlier developmental period, but they may be masked and we may not see them until later life. So this is a new diagnostic criteria that was added, because what we find is if you take 2, say, 6-year-olds, a boy and a girl, the boy might be quite clearly autistic, the girl, we may not be able to make that diagnosis. But then take the same 2 at 12, it may be that they're both very quite clearly autistic. So it recognizes that they would have been present earlier, but we may not have sort of worked it out until later. So it talks about the social demand being more challenging than what they can do. So the other parts of it, it talks, oh, here it just says it here. It talks about the social demand increasing and that then the autistic traits become more obvious. So what we often see is transition to secondary school in girls is a real challenge. So you might have a girl that was quiet, had friends, managed primary school quite well, and then they go to secondary school and all of a sudden they can't navigate the new peer relationships, they can't manage the changed timetable and the constant to and fro and the loudness of the corridors, and then you start to see this child as being more autistic, whereas before it may not have been something that was obvious or picked up. So I've just said that. So I think what the DSM-5 does is it nicely captures these differences in gender, and it shows that girls have increasing impairment as they encounter the social complexities of adolescence, and that females with autism are characterized by features that present in childhood but become less common over time due to camouflaging. So what we might see is a very young child doesn't present as autistic, an adolescent does, and then as they meet adulthood, they then learn even more camouflaging, so then you don't see the symptoms again. So it's really quite complicated. So I think I've probably said a lot of this already, but just to summarize, how do the differences present to us in clinical practice? So the 3DI or the ADI is the kind of parent developmental report. So I think if anybody's been through an assessment process, they would have had quite a detailed developmental history done with a clinician. And what we see in that is that the girls have these interests, but that the interests are really similar to their peers. So fashion, pop stars, we notice that there's less repetitive behaviors talked about, and there's more emotional problems. So we see more of the anxiety, more of the low mood, more of the emotional outbursts than in boys, where we might see more aggressive behavior, more tantrum behavior, more kind of shutting down communication when stressed. In the ADOS, which is the observation that we often do in clinic, we might see that they have good eye contact. So I often, when I assess a girl with autism, like the first 10 minutes, I'm like, well, their eye contact's really good. And as it goes on, you just start to notice that it's either too intense and it's making you feel uncomfortable, or it's fleeting. So they'll do a kind of, yeah, and then it's sort of just a bit off somewhere. So it's much more subtle to pick up. You might notice that in terms of the interests, they can be quite intense. They might be quite typical for their peers, but they're quite intense. And what I've found is with boys, they'll just kind of interrupt what you're doing to talk about what they want to, whereas girls seem to do it much more subtly. So you'd be talking about something, say animals, you say, oh, I've got a pet, and they'll show interest. So that's something boys don't do so much. Oh, what kind of pet is it? It's a cat. And then they'll go, oh, I love cats. Cats are this, and then later you'll be talking and they'll say something like, oh, I did something fun at the weekend. Oh, was it with your cat? Oh, so the cat pops up all the time. The interest pops into conversation, but the way they do it is more subtle and more socially appropriate, I guess. The repetitive behaviors you don't see obviously in the room, but you might notice sort of a sense of control coming through, or a sense of, so often they'll say, oh no, the story's not going to do that way, we're going to do it this way. So they kind of lead things or control things subtly, or repetitive things might happen because they want to do it in a certain way, and you've said, oh, we can finish that now. Oh no, I haven't quite finished, and they sort of make patterns how they want to do it. We might talk about how they have friends, often have a best friend in girls, but maybe there's a bit of mimicking going on or copying, or if the best friend's not around, that young person can't cope, and that they're maybe on the quiet in a group, but actually they're the quieter ones. So often schools will say, no, they're always with a group of girls at lunchtime, they seem fine, they're never falling out with people. Actually, they're not maybe talking, they're not maybe getting involved so much, they're on the edge, they're sort of mimicking what's going on and just fitting in. So that's what we might see in a school observation. So the differences are there, but it's quite subtle. So this new thing's come about in the last 10 years, camouflaging. So we did used to talk a little bit about masking, but I think it's become more obvious to researchers that actually there's people on the spectrum that kind of learn to camouflage and hide their traits, I guess. So what we find is that boys are less likely to do this than girls, and girls, you know, they may want to do the sort of stimming behavior, so flapping their hands or rocking, but they're deliberately not doing that in public because they know that that's unusual behavior. So I think a girl described herself as putting on her best normal. And I've certainly heard of girls that will say, not, you know, in a situation they're not doing anything unusual, and then their parents are reporting, well, when they get home they're just rocking in the chair, or they love to just jump on the trampoline, because if they're not jumping on the trampoline, they're jumping on every piece of furniture, so we got them a trampoline. So they've kind of almost learned how to suppress it and stop it, so that then they can get it all out later. And I suppose the other problem with camouflaging is it does stop people's chances of us noticing the autism. So if they're holding it all in at school and managing to fit in and look normal, if you like, they then at home are presenting very different, but other people aren't seeing that. So you often hear parents saying, well, I don't understand, they're doing all this at school, but at home they're an absolute nightmare because they're having meltdowns, everything has to be really particular. They spend their night rocking or spinning, and it's almost like they've held it all in and it's all coming out in the evening. So this is basically what I've just said. Girls can camouflage in social settings, but then in a safer environment, so maybe home, they might show more of the traits. They may appear shy or struggle to make that first move socially, but they really want friends and they want to fit in. They may struggle with the social niceties, but may mimic rather than naturally respond. So, you know, I meet a young person that often, when I meet her in the waiting room, she'll be like, hello, it's so nice to see you. And as we walk up the corridor, she always picks one thing about my outfit to say, oh, I really like your dress, or oh, your hair looks good today. And I think that's something she's learned to do as a social nicety. Although they make eye contact, it's often fleeting, it's too intense, or it might be quite superficial. So yeah, I explained a bit about that earlier. You don't pick it up initially, but after 40 minutes of sitting with somebody, it becomes quite obvious that it's not normally modulated. Girls show empathy and compassion, but may also confuse some of the non-verbal stuff. So, you know, they may be worried they've upset people all the time because somebody has just raised their voice slightly or said something in a different tone to usual. They're often misreading the social kind of non-verbal cues. So this can mean that they get it completely wrong. And so some girls I've met that are less aware, they want friends, they want to get it right, but they're actually quite in your face and they're misreading any kind of like subtle things of, whoa, you're in my personal space. They're misreading that and they're just carrying on. Or you get girls that too much the other way, they're just so confused by what they see, they're reading everything as negative. I've done something wrong, I've done this wrong, I don't know what I'm doing here. And they become more withdrawn and more likely to not go to school anymore because it's just so confusing for them. Special interest, more socially acceptable, I've talked about that. Speech and language difficulties can often be really subtle, so we don't tend to pick these up. They've usually got very normal language. They've often not got a language delay. In fact, we often hear that they're very articulate. And so it's really hard to pick up those more subtle things, which might be things like not asking for help, not responding with questions to people. So, you know, in an ADOS, you might drop what we call a cliffhanger. So I might say, oh, I went on holiday last week. And people would go, oh, where did you go? A boy will just ignore you, often if they've got autism. A girl will go, yeah, ah, cool. So they've got some set phrases they'll say that sound like they're responding, showing interest, but actually they still haven't done the why, where did you go? What did you do? Because that's socially quite difficult for them. And I guess they may appear quirky in their peer group because, I don't know, they have a unique sense of dress, or they use slightly different vocabulary, or they've got a sort of interest that's a bit more quirky but still fits in. So they tend to be seen as sort of quirky but fit in still, whereas boys just don't fit in so much when they've got autism. I've talked a lot about interests, but what I'll just say is that autistic girls, they can get fixated on a sort of social activity or a popular topic. So and it's really interesting. I meet lots of young people with autism that want to study psychology, and I think it does seem to become a special interest of girls with autism to understand people and to want to study those things, because perhaps they've recognized that people think in a different way to them and they want to understand why that is, and they enjoy topics like that, or they get, you know, completely fixated on a pop star, which, you know, lots of young people do, but it just takes it to another level. And animals is a really popular one as well, and I think it's often because animals are much easier to read and understand than humans, but it's also quite a socially appropriate thing for girls to love animals. I'll send you the slides so you can have a look at this, but this is kind of a summary of what we might see. So I'll pick out a few. They may rely on another child to guide them and help them socially. We may see more depression, anxiety, moodiness. They may have unusual sensory challenges, but these again can be seen differently. So you might get girls that, you know, really love soft things. So I've seen girls that, you know, they have this amazing dress code or dress sense, but they, you know, everything's got a bit of fur on it, and they're just like, when they're talking to you, they just play with the fur, and it's clearly a sensory thing, but it also doesn't look as unusual as a boy who might bring along a sensory toy because that's what they, you know, they're sensory seeking in that way. A girl may just use some of her accessories to do it, and it sort of seems quite appropriate. So strengths in girls with autism. So that was a bit about kind of how we diagnose and how we pick out these differences. And I think from 10 years ago, when I suppose this was quite a big topic, was it 10 years? It was about 10 years ago I was working in that clinic, and we were sort of leading the research in this area. And I suppose I would say now, 10 years later, and coming out of London to a different CAMHS service, it's definitely moved forward, and it's definitely something clinicians are really aware of. So the research has filtered down to different services, we get trained in these things. So when you go to ADOS training and 3DI training now, there's always a section about what's different about girls. And I think schools are much more aware of it as well. And parents. So we often get parents coming, referrals to CAMHS. I think they're camouflaging, or I think they're masking. So I think people are much more aware than perhaps 10, 15 years ago. So that's a positive. And it shows in the statistics that the numbers are coming up to level out with boys more. So let's think about strengths in girls. So they're often a very loyal friend, very trustworthy, very dependable. So often these girls do have a close best friend that they may have had since nursery or for a long, long time. And actually, that friend has potentially helped support them and keep them in social groups. But they're also very loyal to that person and very kind. And often those kind of traits keep the friendship going. The difficulty is when you get to secondary school and perhaps they're split up in different classes, they go and make other friends, and the girl with autism really, really struggles. They might be a truth seeker, so they want to do what's right, they want to find out the truth, they want to behave in the right way. And this can be from, you know, managing the classroom very well to, you know, being the friend that everybody likes because they never say a bad word or they never don't do what somebody's asked them to do. So it's a strength, but it can also lead to them feeling quite overwhelmed. Logical thinker. So I've met some young people with autism that are girls that are, you know, top of their maths class, or I met somebody that had designed, she was very creative and had done artwork, but obviously had designed the whole website to go with her art project, and was out selling stuff on eBay or something years ago. And I was just like, wow, I wouldn't even know where to start to do that kind of, not only the business model, but the IT stuff, and do the actual bit that was her passion. Good attention to detail. So often we'll notice things that others might miss, often quite bright and very good at their work because of this. Have an ability to intensely focus on an interest that actually, the interests usually seem a bit more appropriate, either socially or more helpful for them. So, I mean, I met a girl that was so interested in history, but then went on to get a history degree, and is probably, I could imagine, working now in, I think actually somebody wrote to me once and said she's now got a job in one of the museums, you know, really using her interest and teaching other people about things. Passionate about ideas and problem solving. Someone's determined, they never give up, which might be a challenge at home, because you get these young people that are like, no, we're going to do it this way. And you're just like, oh. Good at spending time alone, and may perceive the world in a unique way, which can always be a positive. So if you look back, there was the food critic person that makes wonderful, unique recipes because they've used their kind of sensory interests and their ability to be creative around their interest in food to kind of put new flavors together. So what I haven't covered today really is what this means and what we do with this. And I said to Jill, we might have to do a different talk, but what we have talked about is how they present differently, what this means. So in terms of girls being at risk of being diagnosed later, so this can have a real impact on their social development, education, mental health and well-being. So in CAMHS, we often see girls around sort of, I'd say 12 to 14 that have come in for severe anxiety, school refusal, really struggling, maybe self-harm. And actually, when you get working with them, we recognise that there's an undiagnosed autism that may not be picked up in primary school, because actually they're functioning okay and they're managing and they're masking, and it's when they transition that these things become more challenging. And I think they continue to mask and they continue to fit in, but the pressure just becomes too much that one day they just can't do it anymore. So you might find with an 11-year-old, you're fighting to get them into school. Come on, you just go in, they're anxious. And then by sort of year 8, it's the friendship groups are also just not happening and falling apart. And the pressure of school work is getting more, and you start to get school refusal. I think what I've also covered is about the DSM-5 changes, which capture these differences in girls pretty well. But I guess it also raises that with more emphasis put on the repetitive side of autism in the criteria, that actually girls might be at greater risk of being missed, because we do put more focus on this side of things. And I think more research and training is still needed, although it's definitely filtering down from the researchers. But this is in order to inform professionals working with children and young people on how to identify ASD in girls at an earlier age. So I think I'm going to stop talking, and then we can have a bit more of a conversation about it. So if I stop sharing, then I can see you. So any questions? So Jill, I know you've got some questions already from other parents that couldn't make it.
Yes, yeah, absolutely. If anyone wants to, rather than talk, wants to put things in the chat, that's fine. I'm happy to read them out, or just sort of let me know. One of the things, I guess, in terms of sort of assessment, is if school aren't seeing the issues that parents are seeing at home, how does that impact on an assessment for autism with girls?
So it does have an impact. So when somebody comes to, I mean, So we've got I'm trying to keep it out of CAMHS. We've got an autism assessment service. So I don't want to tell everybody the wrong information. So when somebody comes saying, I think my child's got autism, we will gather information from the parent. And that is done by an assistant psychologist who is trained in assessing for autism. So they will be asking questions that kind of unpick some of the information around what we know about girls with autism. We will also gather information from the school. So we send a school questionnaire. And school questionnaires for, if we think for primary school with a girl that might have autism, might say, well, they're fine, they've got a social group. Oh, they work really hard. Well, they're quiet, they get on with things, they don't cause us any problems. So they may not have really come to the attention of the Senko or the head teacher or the class teacher, because actually they are managing really well. So there is an argument that if they're managing really well, why are we diagnosing? But we will take into account that sometimes we can't rely on that school report. So if things are really challenging at home, so if what we are seeing is this kind of masking in school, and then at home we've got lots of rigid behaviours, lots of needing everything in a certain way, having to follow routines, examples of not managing birthday parties or social events, lots of kind of difficulties with the social interaction, then we will take that assessment forward if we feel that actually this could be a girl with autism that's high functioning that isn't being picked up at school because they're just not showing it at school. So it's not the school's fault, it's that actually they're masking so well. There will be parents that think, well, actually I went through this process and it didn't get taken forward, and it might be that what you're presenting doesn't sound like autism, so you may have been signposted for some anxiety work, or you may have been signposted for some parenting support, and I don't think that's a bad thing. I think in some cases it's really important, if we're not clear, it's important that we get you support for what is being a problem and then revisit it if it's needed in a couple of years. I think the worst thing we can do is put you on a waiting list, you wait 2 years, we say no, and you've had no support and you're still no further forward with getting support with what you need. I think we recognise that having a diagnosis is helpful, but if it's also getting the support you need. And if it doesn't feel like it's autism at this time, we aim to think about the support first and then revisit it. And I know we've had young people that come for anxiety work, and 3-4 sessions in, so it's only a little wait, 3-4 sessions, you might be saying, well, actually I do think this is something we need to think about. Yeah, does that answer the question?
Yeah, it does. It's good to know that, even if schools can't see it, that there is still an option for an assessment and even,
yeah, I think we don't rigidly say absolutely not. We're looking for autism and we like to see it in different settings, because obviously we're thinking about functional impact as well. Yeah. So if they don't have a functional impact, if they're absolutely fine at home and absolutely fine at school, we're not going to put that young person through that, because the chances are they probably won't quite meet the criteria, and it's not going to help anybody in any way.
Yeah, no, that's great. Thank you. Right, a couple of things in the chat. First one says, for those with delayed diagnosis at 14 who already have anxiety, self-harm, depression, etc., how does the diagnosis then help SEMH if they start getting the right support?
So they've got anxiety, depression. So they're one of those sort of 14-year-olds that get picked up for the emotional side, and then they get diagnosed with autism. How does that help? So from a CAMHS perspective, it really helps to know that a young person's got autism, because we change the way we work with them. So for example, a young person with anxiety, we might do CBT. So cognitive behavior therapy, that's really useful. The evidence base shows that, by exposing somebody to the thing they're anxious about and helping them to manage the symptoms, and also helping them to rethink about how they think about it, will help make that situation different for them. If we're talking about a girl with autism who's struggling to get to school because the noise is overwhelming or the social interaction's too difficult, that approach may not work. It may work, but the goal to get back to school may not be a shared goal with that young person. So they may be saying, well, no, it's just an unbearable environment, I just can't do it. So we can't work on that goal. We also would have changed the way we do that therapy. So we'd make it much more visual, much more structured, so they know what's coming, they know what to expect, they know why they're doing things. And we would have visual kind of things to do in the session, so that their way they learn is more visual than maybe just listening and talking. We also, the way you challenge thoughts is very different, because some of the thoughts we might want to challenge, we may not get anywhere because they're very rigid thoughts and they're not going to change them. So the approach gets changed. And we also know that children with autism and anxiety and depression may not respond to typical treatments. Some will, some just absolutely won't. And it's usually because we need changes to happen in the way other people respond to them, or the way the environment manages them, or the environment they're in is. So we think more broadly, I suppose.
Yeah, thank you. Okay, somebody else popped a question, so that one just shifted up. Okay, somebody said, this has really described my daughter. She managed in primary, we had anxiety diagnosed, but now struggling at secondary school, and most of what was said matched with her. School are looking at a referral. How would this work, please?
Okay, so if you've got school on board, so that's fantastic. School would write down what the struggles are, because I think what you've got is it wasn't picked up early because school weren't struggling, which is what we would probably expect, and we'll continue to expect. So even if we have absolute, we all understand autism girls, it's still, if they're not showing signs of it, we can't diagnose in case they get it. That makes sense. In case they start to present with it. So the process will be, school will fill in a referral form, can go direct to the autism referral service. And I can always send you've probably got it, haven't you, Jill?
Yeah, we've got it.
We'll always send it around to the parents. They can write down the kind of things they've noticed. You will then get, when the referral is received, I'm not quite sure the time frame, but you get a call back a couple of weeks probably, to go through some of the things you've noticed. And then they'll send out some questionnaires to school, which school will return with things on it. And then if it sounds like it's autism, you'll wait on a waiting list to have that assessment. I don't think it's that huge at the moment. I think we're talking, I don't want to say it's six, I heard 30 weeks, so 6 to 10 months, that kind of wait, which is much better than when I started.
That's really good. Yeah, that's really good compared to how it was, for sure.
Compared to where it was 2 years ago when I met Jill.
Yeah, absolutely. Okay, thank you. Right, we've got more coming in. So if a teen girl is presenting with social issues, but mainly sensory issues, has intense interest but not showing any repetitive behaviour, will that result in no diagnosis under the criteria? If they get no diagnosis, will they still get help for the issues they have? I've been told there's no sensory testing on the NHS.
Right, so sensory issues comes under that repetitive restrictive behaviours. So if I'm thinking about the diagnostic criteria, she would score based on those sensory things. If for whatever reason didn't get a diagnosis, there weren't enough traits across the board, we'd then be thinking about what are the impairments, what are the difficulties, so some social difficulties. So what we usually think about is we don't do kind of therapy or medication for helping children with social difficulties. We talk to schools around what can they do to support social difficulties. So often we're talking about having social skills groups, and all schools are really, they know what to do. They've got usually a teaching assistant, a program. Sometimes they get speech and language therapists involved who come and do a kind of set up a program, but it might be things like practicing, taking turns, if you're talking with little kids, or it might be how to start conversations, how to make friends, or with older kids, you might be doing kind of buddying up. So getting another girl that's kind of socially very empathic and kind to support that other girl, in the playground or at break times, so that she has somebody that she can join and helps her socially. So those are the kind of things that we might do with social needs, I suppose.
Yeah, that's great.
I didn't mention the sensory bit. So you're right, we don't do you sometimes hear things called sensory integration therapy. We don't do it on the NHS. And I guess that is just partly because the evidence base for it is not out there yet. I suppose what I always think about is how can you compensate for their sensory things. So if they've got, you know, problems with noise, can they use ear cancelling headphones, or can they listen to music when they're out in public transport, or whatever helps them? Or can you use, if I don't know, if they need more pressure weighted blankets, you know, it's almost like when you go to an OT, you might get a really big assessment that looks into these things and then makes recommendations. But actually, if you know noise is a problem, what can you do to help that person with noise problems?
Maybe I think we'll definitely get you back, Laura, to do a talk about things that can help.
Okay, things that can
Sorry.
help. Maybe James can help me.
Talked yourself into another talk. Right, we've got I will come back to the chat, but we've got a hand up. Gab, it says. Do you want to unmute yourself and you can ask your question?
Hi, I have 2 diagnosed autistic girls, both of whom were diagnosed at age of 7. My eldest is now 12 and has just gone over to secondary school. Obviously, you've mentioned about the anxieties and the overwhelming feelings that the new pre-teens are having within secondary schools. There's multiple areas in which my eldest requires support, and at the moment I'm trying to collate evidence to support an EHCP, but because she's deemed high functioning, so she is in top lessons, she's in top sets for all of her lessons, she applies herself, she puts so much pressure on herself that then her anxieties overwhelm her, which then has a knock-on effect with her work. But I'm finding that I'm just hitting brick walls with regards to the EHCP process, because she is high functioning and not low functioning, you know.
And you probably will, and I know there's a Senko on here, so she might correct me if I say anything wrong. But my understanding of the EHCP process is that, so in Southampton, it seems that people think you need a diagnosis to get one, but that doesn't mean you're going to get one. And I think my understanding of it is that it's needs led. So if she is in top sets and she's doing really well academically, school is not going to identify those as needs. They may identify that she's struggling socially, that she is really anxious and needs some adjustments, and school can absolutely do those without an EHCP. I think, you know, children they used to get put on an SEN register, and which just means that they are a child that has additional needs that the Senko is aware of. But it's thinking about what would help her manage. So if she is struggling with peer groups at lunchtime, say, is there a lunchtime club she can go to that would help give her a structured group of people that she can interact with? Or is there a buddy she could have? Or is there a, you know, sometimes there's a learning support base or something that some kids can go to at lunch because they just get too overwhelmed by the noise. So it's thinking a bit out of the box, but what support can school put in place rather than fighting for an EHCP that you probably won't get because she's.
They have made adaptations, but the adaptations that they've made with regards to a fast pass for lunchtime, so she would have to deal with all the commotion that's going on in the hallways. But I know that schools' hands are tied to a certain extent because of funding. So in order for my child to be supported, I believe she requires more support with regard. Her biggest area of anxiety is PE, and that's because it's team building and it's social skills. And so with regards to filling in the paperwork for the EHCP, PE is of my forefront, you know, because that is all the social and anxiety. I
guess then if that's where it's presenting the most, are there other adaptations? And I don't want to talk for the school because I don't know them and I don't know what they would be able to offer, but sometimes I've heard of young people maybe not going to PE but being taken out by a parent to go swimming or something they can cope with. So they're still meeting the demands of the curriculum, they're still getting some exercise, but we've just said they're not going to go to that because it causes them so much anxiety they can't manage it. So just talking to the Senko or somebody at school around what can we do, because actually she's, you know, I've met young people that, you know, missed 2 days a week because of PE, and we just said, well, the reason they're not coming in these days, they don't want to go to PE, and school just said, oh, well, what do they like doing? Right, well, they can go and use the school gym for an hour instead. Or, okay, they don't come in for that lesson, they go to the learning support base, but you take them swimming after school. So they're, it's things like that. So there's a lot of adaptations that can be done that maybe don't cost money. And if schools are flexible around it and it's going to help that young person, I think it's worth pursuing that.
Can I answer that question that just popped up? Sorry.
Yeah. Oh, I didn't see one. Sorry.
Parents aren't allowed to self-refer for an EHCP anymore. They don't. Well, they can, but it doesn't hold up much ground. I was told by Arsenko that it doesn't hold up much ground as if it comes from school. If it comes from school,
you can still self-refer. I'm in the middle of self-referring at the moment. It's definitely better if schools are on board, but we have a lot of parents who have fought and have managed to get it themselves. But it's much more of a battle.
And it is a battle. And I would be thinking, rather than fighting for the EHCP for 2 years, just talking to the school about what can we do to be a bit flexible that meets the needs of this young person, that doesn't cost loads of money and doesn't cause lots of issues. I was just also thinking, if you think that the anxiety is high, and I don't know what school she's in, but if it's a Southampton one, most schools have something called MHST, which is the Mental Health in Schools team, and whether she could get some support from them. So if you speak again to schools,
again, that referral was supposed to have gone in about 3 weeks ago, and the Mental Health in Schools team don't take parent referrals, they only take school referrals.
They do only take school referrals. And again, it's just chatting to your school about it. But I think you're on the right things, you're on the right path. Sounds
Thank
like
you.
You're advocating really well for her. And also Sendias are really good to help support
you. Yeah, thank you.
Thank you.
Brilliant.
Okay, the last few questions. So how is CAMHS currently viewing autism with a PDA profile? As I understand, it's not yet a recognised diagnosis.
Oh, that's a random one, but one that we always get. So in relation to girls, I don't really separate girls and boys in this answer, but what we know is PDA is a subset of autism. So there is a research group that have come up with this pathological demand avoidant subset, and they are diagnosing people privately with that, but we don't do that on the NHS, partly because it's not recognised. There's not enough research to recognise it to get it into things like the NICE guidelines, which is what we're adhering to, which they are very much evidence-based. And they look at lots of research, and they will put the research together and then make the guidelines of what a good assessment looks like, and that's what we follow. So if somebody comes along with a PDA diagnosis, I would look at it as they're probably autistic. So whether they've got that diagnosis or not, we might look at them and think of it as autism, but we would think of it as autism with a subset of oppositional and defiant behavior that responds in a slightly different way. So I know there's lots of strategies that parents find helpful from PDA, which is around kind of just not putting in those demands, but getting them on board for those demands a bit more. So I wonder if you could beat me with putting your shoes on. I wonder if you would be faster than your brother. So that kind of more gentle demands, because the demands, I think, make them anxious, and then they go, no. So it's about understanding what that profile is, but probably in the context of autism.
Yeah, we have a video, I can't think who did, it was either you or Chantal, did about demand avoidance. So with lots of strategies. Yeah, so many talks, Nora. So somebody said the wait time you mentioned, is that Southampton or Hampshire? Obviously we're talking about Southampton CAMHS here. Would the child being put on a child in need plan with social services impact on the wait time? So I guess, do you get escalated if you're a child in need?
I don't know. I don't think you do. So I can talk about ADHD because that's within CAMHS, and I expect the autism service work in a similar way. We will prioritise young people for an ADHD assessment if there is significant risk that means that understanding this child as ADHD is what is absolutely needed. And that is a very rare thing that we do, because really, if we think of a child with ADHD or autism, we're thinking of them as having additional needs. We know what those needs are, and then we need the network around them to support those needs. So whether that's having some, if a young person is suicidal and self-harm, we need to have risk management and therapeutic work to support those needs. And we need to maybe look at that in a lens of autism if they're on a waiting list for autism. We need to have, social care involvement if they're on a SIM plan or a child protection plan, and we need to make sure that they're following what they need to be doing, and the network is supporting that family for whatever those needs are. And the diagnosis will happen at some point. So we don't tend to prioritize people. But if you've got loads of concerns that, it's the diagnosis that's the thing that's absolutely needed, you can always ask somebody whether that is something that can be done.
Yeah.
Probably shouldn't have said that.
We won't tell anyone. Thank you.
Yeah.
Right, last question. My daughter was diagnosed with autism, and her diagnostic report from Psycon states that it was just autism. But at the assessment, when we received the diagnosis, the doctor said there was possible ADHD, mild learning difficulties, and dyslexia. Over the last few months, she has started to show so many more signs of ADHD, and I wonder if it's worth going back through the assessment process to get a diagnosis.
So my question is, because Psycon and clinical partners who we have now have been referring in to ADHD assessments if they had concerns.
Okay.
So does the report clearly state that, and that they were making a referral, and you haven't heard, in which case we need to work out who you are and see why you've not been referred. If it doesn't state that, I'd perhaps, in this case, ring up the autism service and say, look, it mentioned this, but it doesn't look like I was referred. What do you think should do? And now it'll probably instigate a referral. In terms of dyslexia, we don't assess dyslexia and mild learning needs. That would be go back to the school and see what they can do, to what they understand about it and what they can support within that terms. But the ADHD, if usually, particularly clinical partners, I'm not quite sure what was going on with Psycon, but I think they were referring into ADHD assessment if we needed that.
Okay. And that parent's really welcome to come along to one of the advice clinics if she can wait until September when we sort of start them again. Or in fact, we've got a CAMHS one next week. But so just sort of let me know if you want some more help.
Yeah, and then somebody can look it up for you and things.
Yeah, absolutely. Gab, you've got your hand back up. Is that a new hand?
Yeah, I have. I don't know what happened there. Can you hear me?
Yeah.
Okay, so with regards to the autism in girls, much like my youngest, she's just been diagnosed through the clinical partners. It came up loosely in conversation in the 3-hour assessment thing of inattentive ADHD. Does that display a lot similar to autism? She has now got a diagnosis of autism. Are they much the same likeness, or is there differences with regards to the inattentive ADHD to the autism?
There are differences, but there's also such overlap and such similarities. So again, I'd be saying, did they say they need to refer? Because if they didn't refer, so clinical partners are being really good on it. Psycon were the people before that. I'm not sure, I can't remember, I can go and find out afterwards and let Jill know. I wasn't sure what the process was as to whether they were then referring in, but clinical partners have a clear pathway into CAMHS if they think there's a referral. I think one of the problems is that they will often say, oh, they're quite inattentive, but that doesn't mean that they need further assessment. It might just be a trait of the autism as part of the autism, or just part of being a 7-8-year-old. So what's the difference? So firstly, in children, ADHD is we usually see ADHD, we usually see the hyperactivity. ADD is more in teenagers and adults. It can exist in younger girls, very, very, very rare in boys. It's about you'll see the inattentive, distractibility, losing sentences, drifting off, maybe changing topics in conversation. But a lot of these things are also, if you're autistic, you might drift off out of a conversation you're not interested in. You may change the topic of conversation because you want to talk about something else. You may not see the relevance in doing your maths homework, so you drift off and think about your special interest. So there is a lot of overlap, and I'd probably say if they haven't referred you, I would just keep an eye on it and see if it's something that becomes more obvious as she gets older.
We have a really good, we have a really good video about ADHD in girls.
Brilliant.
On our YouTube channel. The CAMHS did a really good talk, because I think a lot of us were surprised at some of the things and how it shows in girls. So it's well worth a watch if you're concerned about that. And
I would also say, if she's just been diagnosed, get the work around the autism done. So school understanding that she's got autism, thinking about what adjustments to do, and then see if that helps. Because if we can get those things in place and that helps, then there's probably no need to further assess. Yeah, hope that helps.
Okay. Brilliant, thank you.
Laura, thank you so much. That's been really helpful. We definitely will get you back for a more practical of how to support and what we can do in that sense. But it's been a really useful morning. Thank you ever so much for your time, and thank you everyone else for joining us today.
Great, nice to meet you all.